Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is BLEB related endophthalmitis. This is a possible complication after the filtration surgery for the glaucoma. These are the fundus photographs of a patient suffering from chronic angle glaucoma. In spite of peripheral iridotomies, patent and full medication, he had advanced glaucomatous changes and the pressure was not getting controlled. So decision was made to go for the deep sclerectomy with mitomycin eye drops. So these are the two slides you are seeing here of a patient who has undergone deep sclerectomy, and you can see thin blebs +2 formed over there. No signs of infection, no leakage, nothing like that, and it is a perfect surgery. Intraocular pressure was well controlled. There was no sweating, no micro leakage. Yes, in these two slides it is shown. As I mentioned, the endophthalmitis can happen. It can present with the early onset blebitis and it can present late. So this is you can see that late complication of this patient. You can see there is inflammation along over there, the blood vessels over there, and redness, mild tenderness, pain over there in these two slides shown over. And managed with topical antibiotic drops, moxifloxacin eye drops. This is the early presentation with keeping in the mind that as compared to the previous photographs, almost 7 years have passed. This is the typical photograph of a BLEB-induced endophthalmitis. You can see white on red presentation. There is hypopyon, ciliary congestion. BLEB is white, inflamed, and it is now, you can see the anterior chamber, there is hypopyon, all around ciliary congestion. So the infection has spread now in spite of the previous treatment. The other photographs of the same patient, you can see ciliary congestion 360 degree with BLEB inflammation, infection, hypopyon, anterior chamber reaction, pupillary membrane even can be seen. So now this is advanced stage. Hypopyon is more clearly shown. It is almost 1/3 of anterior chamber height, and you can see pupillary membrane over there. So the infection is quite extensive and aggressive. And as we know that endophthalmitis involves the vitreous. So this is the vitreous activity over there. You can see hazy vitreous. Along with it, mild retinochoroidal thickening can be seen. So now this is a fully established endophthalmitis case secondary to the blebitis. Once these patients develop endophthalmitis, they have to be followed the endophthalmitis protocol, intravitreal injections, vancomycin and ceftazidime, along with the vitreous tap, topical fortified vancomycin and ceftazidime eye drops should be given half-hourly alternatively. Along with that, intravenous antibiotics can also be introduced. And if the condition does not improve, surgical intervention in the form of core vitrectomy can be done. Because now this is eyesight-threatening condition. So this shows that blebitis can be how much serious. If we talk about the classification of the infections because of this, usually classified as blebitis or BLEB-related endophthalmitis. Stage 1 or grade 1, this is simply localized blebitis. Grade 2, it is said that blebitis plus anterior chamber reaction. And if we talk about the third category, it is blebitis plus endophthalmitis. The blebitis can present early and as late. Even up to 5 years, 7 years, they can present. And there are multiple risk factors which we will discuss about this type of infections. So if we talk precisely about blebitis, it is usually initially a localized type of infection which causes hyperemia and anterior chamber activity, mild tenderness and pain over there at the location site. And most likely the contributing factors are that the patient has some micro leakage or sweating over there from the wound site. Some surgical wound manipulation has been done over there, or use of the antimetabolites which have made the BLEB avascular. And apart from this, any micro leakage makes a communication with the tears. Patients may have some infection in the eye like conjunctivitis and nasolacrimal duct obstruction, blepharitis. All these things can contribute to the even when we talk about the limbal based incisions approach. All these are the contributing factors for the blebitis. So if we talk about early leakage, this usually happens within the first 3 months. It is because of the dehiscence of the wound, or because of the incomplete conjunctival closure. But when we talk about the late leakage, this is because of the use of the antimetabolites, for example 5-FU and mitomycin C. It causes thinning of the conjunctiva, acellularity over there, goblet cells are damaged. The loss of goblet cells lead to less production of mucin layer of the tear films, so there is less protection. So all these factors contribute to the thinning and leakage of the BLEB lately. When I talk late, it can go up to 5 years, 7 years also. And one thing very important during surgery, that proper conjunctival dissection should be done so that the BLEB is formed is a diffused one, not a localized and tender. When it is a diffused one and the aqueous is going diffusely under the conjunctiva, there are less chances of leakage. So these are the two things, the early and the late onset leakage. So as far as the clinical features, the same I mentioned earlier: pain, redness, inflammation, tenderness at that site, reduced vision, opacified BLEB over there. These are the clinical features: white on the red appearance. And sometimes the inflammatory deposits are so much over there in blebitis that the aqueous drainage is compromised. And usually the most common pathogens we see over there is the Staph aureus and Staph epidermidis. If we talk about the early infections, it is usually coagulase negative Staphylococcus. And when we talk about the late onset, mostly the streptococcal infections are found. Talk about BLEB associated endophthalmitis. The risk factors are the same as I mentioned earlier, that BLEB leak, thin BLEB, nasal BLEBs, and high BLEBs, intraoperative use of mitomycin C, limbal based approach, hypotony, conjunctivitis, blepharitis. If we do multiple procedures with trabeculectomy, they all can contribute. Inferior BLEBs as compared to the superior BLEBs have more chances of developing because there is no more protection from the eyelids, and the BLEB is persistently soaked by the tear film over there. So all these things can contribute. The causes are almost the same as we mentioned about blebitis, but the thing is the aggressiveness and the severity of disease is quite multifold. Yes, this is a stage alarming where the infection has gone inside the eye. It is no more outside. Now it is encroaching, and the vision, as the time passes, the vision and the prognosis keeps on decreasing. So earlier we were usually following the approach of the early vitrectomy study, that intravitreal antibiotics can be given if the vision is, hand movements are better. But in such patients, if the patient's physician feels that things is aggravating and not getting controlled in spite of the intravitreal antibiotics, he can go for early intervention for core vitrectomy. The early diagnosis in the management of blebitis is very important. The patient, if has poor compliance, if physician feels that he is not going to use the medicines properly, these patients should be admitted. And as I mentioned, fortified antibiotics, vancomycin and ceftazidime eye drops, can be started half hour alternatively for first 48 hours, and once the infection gets controlled, then these can be tapered off. Meanwhile, a conjunctival or eye swab should also be taken prior to starting the antibiotics to give us an idea about Gram and Giemsa staining, and anything beneficial from microbiology will be helpful. The blebitis at this stage management is quite easy, because the same bacteria which are found around the eyelids, margins, and eye growth, the bacteria, the same are responsible for causing these types of infections. So it should be aggressively and seriously managed at this stage, because once the infection goes into the eye, then it makes big problems. This was a case I wanted to discuss with my respected audience, that how BLEB related infections can be so aggressive and virulent if they are not properly managed. The microleaks should be taken seriously, regular follow-up should be done, every time serial test should be done to see any sweating, any micro leakage over there, and it should be addressed properly. If we find any blebitis, it should be aggressively treated, and if we feel the patient has poor compliance, he should be admitted even for the blebitis. Because in the blebitis, as I mentioned, the infection can go straight away, because the aqueous is draining and getting filtered. This is now in direct contact with the infection. If you make a comparison with the anterior chamber, for example, microbial keratitis, there are multiple layers which are protecting over there: corneal epithelium, stroma, decimus membrane, endothelium. But here, once the infection is in the BLEB over there, the aqueous humor is in direct contact over there. If the aqueous can come outside from the eye, the same infection from the BLEB will take no time, if not properly controlled, to reach into the eyesight. So especially the aggressive risk factors I mentioned, if the metabolites have been used, especially thin-walled BLEBs and localized tense BLEBs, and all these things should be kept in mind whenever the patient follows up with us. So I want to thank my respected audience for their attendance and attention. I hope this case will be beneficial for their clinical practice. Thank you.